Systemic lupus erythematosus, or SLE, it's a systemic connective tissue disorder characterized by extra-articular and articular manifestations, most probably autoimmune. The etiology is still questionable, most probably autoimmune defect in T suppressor lymphocytes, leading to increasing of autoantibodies, immune complexes which can involve tissue anywhere in the body, and systemic manifestations. Genetic factor, positive family history and HALA association, HALA DR2 and HALA B8. Environmental factors, sunlight, infections may play some role. Drugs, drug-induced lupus, hydralazine, INH, penicillamine, and phenytoin. Hormonal factor may also play an important role, estrogen, and that's why SLE is common amongst females, especially in childbearing period, exacerbation in pregnancy, unlike rheumatoid arthritis, which was relieved during pregnancy. Pathology, articular synovitis, which is usually not erosive, no cartilage destruction, extra-articular deposition of immune complex in a variety of areas of the body, skin, kidney, glomeruli, heart, lung, CNS. When only skin is involved, this condition is called discoid lupus, and when internal organs are involved, this condition is called SLE. Clinical picture, more common amongst females, as we mentioned, from 20 to 45 years. From females to male ratio is 10:1. General, fever, fatigue, sweating, extra-articular manifestations. We have skin, malar rash, erythema over the cheeks, butterfly rash, erythema over the cheeks and the nose, discoid rash with mnemonic SBAT, erythema, scar formation, skin pigmentation, and telangiectasia occurring over the face and the neck, photosensitivity, skin rash as a result of unusual reaction to sunlight, alopecia, vasculitis, purple, leg ulcer, Raynaud's phenomena, poor circulation to the fingers and toes with cold exposure. Renal manifestations, or lupus nephritis. Renal disease is common. The drug-induced lupus rarely affects kidneys. Patients with lupus nephritis generally have abnormalities in urine analysis, proteinuria, either asymptomatic or up to nephrotic range. Hematuria and red casts may be seen. Acute or chronic renal failure may develop. Needless to say that patients may suffer from other symptoms of lupus unrelated to kidney function, such as arthralgia, fever, fatigue, psychosis. Renal biopsy should be considered in any patient with SLE who has clinical or laboratory evidence of active nephritis. Lupus nephritis occurs from 30 to 70% in patients with SLE, and you should know that the diagnosis is based on combination of renal biopsy with immunological tests such as anti-double-stranded DNA with low complement 3 and low complement 4. WHO classification of lupus nephritis. They are divided into 6 classes, class 1, 2, 3, 4, 5, 6. Class 1, normal glomeruli, mild proteinuria. 2, mesangial affection, asymptomatic proteinuria or hematuria. This form typically responds completely to treatment with corticosteroids. Class 3, focal proliferative glomerulonephritis, responds to treatment with high-dose corticosteroids. Diffuse proliferative glomerulonephritis. This form is mainly treated with corticosteroids and immunosuppressive drugs. Membranous glomerulonephritis, class 5, characterized by extreme edema and protein loss, nephrotic syndrome. Class 6, sclerosing glomerulonephritis, significant renal insufficiency or end-stage renal disease in most cases, unlikely to respond to medical therapy. Cardiac manifestations, pericarditis, myocarditis leading to heart failure, Libman endocarditis, non-infective endocarditis, aortic and mitral regurg, systemic hypertension, ischemic heart diseases, accelerated atherosclerosis, chest manifestations, pleurisy, pleural effusion, interstitial pulmonary fibrosis, pulmonary infarction, shrinking lung syndrome, pulmonary hypertension, and ARDS, adult respiratory distress syndrome, CNS, headache, depression, chorea, neuropathy, epilepsy, myopathy, cerebral vasculitis or lupus cerebritis leading to stroke. Nervous manifestations may be due to diffuse cerebritis, vasculopathy, thrombosis, infection, or drug effects. Eye manifestations, conjunctivitis, scleritis, anterior uveitis, retinal vasculitis. GIT, nausea, vomiting, painless oral ulcer, esophagitis, gastritis, peptic ulcer, vasculitis, abdominal pain, pancreatitis, and hepatosplenomegaly. Blood manifestations, decreased RBCs, anemia of chronic disease or hemolytic anemia, decreased platelets or white BCs due to the disease itself or side effect of pharmacological treatment, antiphospholipid antibody syndrome, thromboembolism, lymphadenopathy, splenomegaly are frequently seen. Articular manifestations, distribution, polyarthropathy, symmetrical, affecting mainly peripheral joints in the upper and the lower limb, and affecting mainly small joints such as hands and feet, usually not erosive, so there are no deformities. Description, arthralgia more than arthritis, and myalgia is common, so we have pain only, deformity is rare, and it may occur due to tendon or ligament laxity. Necrosis of hip is due to steroid therapy. Pregnancy and SLE. Fertility is unaffected, but we have exacerbation during pregnancy. Preeclampsia, abortion may occur frequently in pregnant patients with lupus, and child born to mother with SLE is more likely to develop skin manifestations and congenital heart diseases. Cause of death in patients with SLE, stroke, myocardial infarction, infection, nephritis, and it increases the risk for developing cancer of blood and breast with coronary diseases. 10-year survival is more than 90%. Investigations, blood picture, anemia of chronic disease or hemolytic anemia, leukopenia, less than 4,000 per millimeter cube, thrombocytopenia, less than 100,000 per millimeter cube, lymphopenia, elevated ESR, normal CRP, but it's elevated only with infection, decreased C3 and C4, they are consumed. Serological tests, non-specific antibody, we have LE cells positive in 80% of the cases, rheumatoid factor positive in 25% of the cases, anti-nuclear antibody positive in 95 to 100% of the cases. This is the most sensitive. Positive anti-nuclear antibody is not diagnostic, but negative test argues strongly with SLE. Causes of positive anti-nuclear antibody is it's positive in 5% of the normal population. It's also positive in 60% in Sjogren syndrome, infective endocarditis, old age, primary biliary cirrhosis, in 30% of rheumatoid arthritis, and 90% of scleroderma. Specific antibodies, we have anti-double-stranded DNA in high touch. It's very specific to SLE. Anti-Smith or anti-SM indicates poor prognosis. Anti-RO-SSA, anti-LA-SSB, found in anti-nuclear antibody negative lupus. Anti-histone, specific to drug-induced lupus. Anti-cardiolipin antibody, anti-phospholipid antibody syndrome. X-ray, osteoporosis, chest X-ray shows pleural effusion, aspiration of synovial fluid, it shows the antibodies. Investigations for lupus nephritis, urine analysis, and KIFT, kidney function test. In one word, investigations, scheme plus lymphopenia, decreased C3 and C4 with renal function test. The 11 criteria used for diagnosis of SLE according to the American College of Rheumatology: 2 rash, 2 antibody, and 7 Ps. 2 rash, malar or butterfly rash, and discoid rash. 2 antibodies, positive anti-nuclear antibody, positive anti-double-stranded DNA antibody or anti-SIM antibody, anti-Smith antibody. The 7 Ps are photosensitivity, painless oral ulcer, peripheral joint arthritis, 2 or more peripheral joints, pleurisy or pericarditis, proteinuria, psychosis or seizures, and pancytopenia. The diagnosis of SLE is strongly suggested when a person has 4 or more of those criteria. Then we have 2012 SLEC criteria, SLICC, for SLE, Systemic Lupus International Collaborating Clinics, unimportant to know the abbreviation. Classify a patient as having SLE if the patient has biopsy-proven lupus nephritis with ANA or anti-DUS DNA antibodies. ANA is anti-nuclear antibody, or the patient satisfies 4 criteria, including at least 1 clinical and 1 immunological criteria. Clinical criteria are acute or subacute cutaneous lupus. Acute is the malar rash or photosensitivity, while the subacute is annular or psoriform patch. Chronic cutaneous lupus is a discoid rash. Number 3, oral ulcers, palate, buccal, tongue, or nasal ulcers in the absence of other causes such as Bassett. 4. Non-scarring alopecia, diffuse thinning and hair fragility with visible broken hairs in the absence of other causes of alopecia such as alopecia areata, drugs, iron deficiency, androgenic alopecia. Number 5. Synovitis involving 2 or more joints. Number 6. Serositis, pleurisy for more than 1 day or pleural effusion or pleural rub. Pericarditis, pericardial effusion or pericardial rub in the absence of other causes such as infection and uremia. Renal, number 7, proteinuria exceeding 500 mg per day or red blood cell casts. Neurological, number 8, seizures, psychosis, myoneuritis multiplex, myelitis, peripheral or cranial neuropathy. Hemolytic anemia, leukopenia less than 4,000 per millimeter cube or lymphopenia less than 1,000 per millimeter cube at least once in the absence of other known causes such as Felty syndrome and drugs. Thrombocytopenia, number 11, less than 100,000 per millimeter cube at least once in the absence of other known causes of drugs such as TTP. And then we have immunological criteria: ANA, anti-DUS DNA, anti-SEM, antiphospholipid antibody, lupus anticoagulant, high titer anticardiolipin, low complement, low C3 and low C4, direct Coombs test in the absence of hemolytic anemia. Again, ANA is anti-nuclear antibody, anti-DUS DNA, anti-double-stranded DNA, and anti-SEM is anti-FMEF. Treatment of SLE. There is no cure for SLE. It's considered incurable but highly treatable. The goal of treatment is to relieve symptoms by decreasing inflammation and decreasing the autoimmune activity. Depends on severity and organ involvement. General prophylactic measures: rest, avoid drug-inducing SLE, psychological treatment. Sensitivity to light is treated by protective clothing, sunglasses and sunscreens. NSAIDs are used to treat arthritis and pleurisy. Cortisone for extra-articular manifestations. Topical, cortisone cream for skin rash. And systemic, pulse dose 1,000 mg per day IV for 3 days, followed by 60 mg per day till the activity of the disease disappears by decreasing symptoms and signs with negative anti-double-stranded DNA, then followed by maintenance dose 10 to 15 mg per day. The side effects of cortisone are hyperglycemia, moon face, buffalo hump, osteoporosis, muscle weakness, sodium and water retention, hypokalemia, hypocalcemia, delaying wound healing, cataract, glaucoma, nervousness, insomnia, psychosis, hypertension, heart failure, thrombosis, chest infections, increasing gastric acidity, teratogenicity, menstrual disturbance, hirsutism, and sudden withdrawal of steroids can lead to adrenal crisis. So it's important to know that since those side effects are present, cortisone is contraindicated in diabetes mellitus, Cushing syndrome, myopathy, wasting, hypertension, hypokalemia, rickets, and osteoporosis, uncontrolled infections, cataract, glaucoma, psychosis, hypertension, heart failure, TB, peptic ulcer, pregnancy, and avoid sudden withdrawal. You need also to know that steroid preparations are used for replacement therapies, suppression therapies, or supplementary therapy in non-endocrine diseases. Suppression therapy such as tissue transplantation, lymphoma, and leukemia. Replacement therapy, Addison's disease or congenital adrenal hyperplasia. Supplementary therapy in non-endocrine diseases, anti-inflammatory, anti-allergic, such as for the CNS, it's used in increased intracranial tension, cerebral edema with neoplasm. In the CVS, it's used for rheumatic fever, hemolytic anemia, ITP, idiopathic thrombocytopenic purpura, post-infarction syndrome or Dressler's syndrome. For GIT, it's used in chronic hepatitis, ulcerative colitis, and Crohn's disease. For respiratory system, it's used in COPD, bronchial asthma, sarcoidosis. Renal, certain types of glomerulonephritis, collagen disease, SLE, polymyositis, PAN, polyarthritis nodosa, and rheumatoid arthritis. Allergic diseases, it's used in anaphylaxis, and for inflammatory conditions, conjunctivitis in the eye, eczema in the skin, and it's also used as an anti-stress and anti-shock. Then we have hydroxychloroquine. We are back to the treatment of SLE. Hydroxychloroquine is sometimes used with cortisone, low dose for skin manifestations and arthritis resistant to NSAIDs. Immunosuppressive drugs for severe cases resistant to cortisone therapy, MAC, methotrexate, azathioprine, cyclophosphamide. Plasmapheresis in SLE patients with serious brain or kidney manifestations. Treatment of complications, removal of spleen is sometimes done for thrombocytopenia and end-stage kidney damage. We apply dialysis and kidney transplantation. Then we have variants of lupus, drug-induced lupus and antiphospholipid syndrome. Drug-induced lupus, more common in males, history of drug intake, hydralazine, INH, phenytoin, penicillamine, prokinamide, alpha-methyl dopa. There is no contraindication to using these drugs in idiopathic SLE. Renal, CNS, and skin features of SLE are rare in the drug-induced lupus. Unknown pathogenesis. Investigations. We have positive antihistone antibody with ANA anti-nuclear antibody, but anti-double-stranded DNA antibody is absent. Treatment. Withdrawal of the drug, short course of steroids are all what we need. Antiphospholipid syndrome. Recurrent attacks of venous or arterial thrombosis and thrombocytopenia in association with laboratory finding of antibodies against phospholipids. Classification. We have secondary and primary. Primary occurring in patients without clinical evidence of other autoimmune diseases. Secondary occurs in association with autoimmune diseases such as lupus. Clinical picture. Vascular thrombosis, cerebral infarction, less common, coronary, retinal, and visceral. Venous thrombosis, especially deep venous thrombosis. Obstetric, recurrent abortions, more common in the second and third trimesters. Cardiac, valvular insufficiency, Lippmann endocarditis. Non-thrombotic neurological symptoms, migraine, chorea seizures, Guillain-Barré syndrome, or dementia. Mechanisms of thrombosis in antiphospholipid syndrome, activation of endothelial cells. Antiphospholipid antibodies interfere with the function of phospholipid binding proteins involved in regulation of coagulation. So we have affection of endothelial cells by their activation and interference in the function of phospholipid binding proteins involved in the regulation of coagulation. Investigations. Lab, CBC, anemia, thrombocytopenia. Serological tests. We have anti-cardiolipin antibodies, IgG and IgM. Anti-beta-2 glycoprotein 1 antibodies, IgG and IgM. Imaging studies for confirmation of a thrombotic event, CT and MRI of the brain, cerebral stroke, chest, pulmonary embolism, abdomen, Budd-Chiari syndrome, Doppler and ultrasound for DVT, 2D echocardiography for detection of endocarditis and valvular insufficiency. Treatment of thrombosis, IV or subcutaneous heparin, followed by warfarin therapy during pregnancy. Patients with history of thrombosis receive therapeutic doses of heparin during pregnancy with long-term anticoagulant for postpartum periods. IV steroids, cyclophosphamide, and finally plasmapheresis. And now we're going to discuss gout. Definition. It's a disease that's characterized by tissue deposition of monosodium urate crystals due to hyperuricemia, which results in gouty arthritis, tophi, and gouty nephropathy. Gout is the most common type of inflammatory monoarthritis. Purines are converted to IMP, inosine monophosphate, then hypoxanthine, xanthine, and uric acid. From IMP to hypoxanthine, we need Hagbert enzyme, which is called hypoxanthine guanine phosphoribosyl transferase. I think it's not important to know the abbreviation. Etiology: increased production of uric acid, metabolic gout; decreased excretion of uric acid, renal gout. Metabolic gout, primary, enzyme defect in defective Hagbert, decreased. Secondary, leukemia, lymphoma, sarcoidosis, severe psoriasis. Excretion or renal gout, primary, idiopathic, isolated tubular defect. Secondary, renal failure, acidosis, increased lactic acid production from alcohol or starvation. Hyperparathyroidism and hypothyroidism, dehydration, decreasing renal flow. And finally, drugs such as diuretics, pyridinamide, low-dose aspirin. Causes of hyperuricemia: allopurinol, Fanconi syndrome, pregnancy due to increased GFR. Acute gouty arthritis: the uric acid itself is not irritant to joints, and urate crystals can be found in asymptomatic joints, but when they are phagocytosed by macrophages, lysosomal enzymes are released, leading to inflammatory reaction, yielding acute gouty arthritis. Chronic gout: deposition of uric acid in tissue, tophi, kidney, gouty nephropathy, joints. Chronic erosive arthropathy. Clinical picture: it's more common in males than females from 40 to 50 years. Then we have asymptomatic hyperuricemia. It's just elevated level of uric acid. 90% of hyperuricemic patients never develop gout. Symptomatic: acute gouty arthritis. Precipitating factors: excess protein, alcohol, thiazide, Lasix, surgery, trauma, infection, dehydration. Distribution: monoarthritis, usually in the first metatarsopharyngeal joint of the big toe, other sites, ankle, dorsum of the foot or knee, occasionally joints of upper extremity, and sometimes the heel. It's not erosive at all. Hotness, redness, tenderness, swelling, limitation of movement. Acute attack is severely painful and it develops overnight, reaching a peak within hours, usually in the morning. Dramatic relief of pain with colchicines is suggestive. Slight fever and chills may be present, no deformity, and differential diagnosis of acute arthritis. It should be differentiated from other causes of monoarthritis, which are rheumatic fever, atypical rheumatoid arthritis, septic arthritis, pseudo-gout, and finally traumatic heme arthrosis. Chronic gout arthritis, polyarthritis, asymmetrical, deformity, yes, erosive, remission and exacerbation, gouty nephropathy, precipitation of uric acid, intrarenal tubules leads to acute renal failure, intrarenal interstitium leads to chronic renal failure and chronic interstitial nephropathy, intraurinary tract leads to nephrolethiasis or urate stones, hematuria infection. Tophi occurs with severe hyperuricemia. Deposits occur usually in skin around joints and extensor surface of fingers and ear lobule. It may ulcerate and discharge chalky paste material. Investigations: uric acid, normally it's from 2.5 to 7 milligram percentage. So its level would exceed 7 milligram percentage in males and 6 milligram percentage in females. It's a biochemical hallmark of gout, but not by itself diagnostic for gout, because minority of patients with acute gout show normal serum uric acid. X-ray, soft tissue swelling around the affected joints, punched out lesion and deformity in chronic gout. Aspiration of synovial fluid or arthrocentesis is the single most useful diagnostic study in initial evaluation of monoarthritis, and you can find urate crystals by polarized microscopy, biopsy from tophi, blood picture, leukocytosis, elevated ESR and CRP, and ultrasound for the kidney. Treatment: asymptomatic hyperuricemia, no need for treatment except with positive family history, uric acid exceeding 11 milligram percentage or increased excretion of uric acid in urine. Acute gouty arthritis in SAIDs, don't use aspirin because it alters uric acid level, but we use diclofenac and indomethacin 75 milligram and then 50 milligram per 6 hours for 2 or 3 days, diclofenac 75 milligram and then 50 milligram per 6 hours, colchicine 1.2 milligram first dose, followed by 0.6 milligram 1 hour later. Side effects: diarrhea, vomiting, contraindicated in renal failure. Then short-term cortisone. Chronic gout, we use hypouricemic drugs. Diet: avoid alcohol, avoid excessive meat, fish, poultry intake, excessive fluid intake, 2 to 3 liters per day. Try other good proteins such as eggs. Medical treatment: allopurinol, Zyloric, dosage 100 to 300 milligram per day. It's Dansen oxidase inhibitor. Side effects are fever, diarrhea, allergy, bone marrow depression. It's not used during the acute gouty arthritis because it may aggravate the attack. Then we have a new Dansen oxidase inhibitor. The dosage is 40 milligram per day. Its side effect is nausea, diarrhea, rash, arthralgia, headache, increased hepatic serum enzyme. It's called febuxostat because there are some people with febuxostat. I'm sorry, I'm really sorry. I'm sorry. Uricosuric drugs, probenecide, dosage 0.5 to 1 gram per 12 hours, used with alkalization of urine. And we have pegloticase, new drug for treatment of severe treatment refractory chronic gout. Pegloticase, recombinant person-like uricase. It metabolizes uric acid to allantoin, and this reduces the risk of precipitates because allantoin is 5 to 10 times more soluble than the uric acid. Pegloticase is given as IV infusion every 2 weeks, joint aspiration and intra-articular injection of cortisone. Then we have prevention of nephrolithiasis by urine alkalization by using sodium or potassium citrate or acetazolamide, 500 milligram at bedtime. Excessive fluid intake, 2 to 3 liters per day. Then we have pseudogout and pseudo-pseudogout. Pseudogout, chondrocalcinosis, deposition of calcium pyrophosphate crystals in cartilage, causing monoarthritis, which is clinically indistinguishable from gout. Etiology: idiopathic. It can occur with certain metabolic diseases such as diabetes, chronic renal failure, hypercalcemia, hemochromatosis. Clinical picture: it's equal in both genders, monoarthritis, especially in the knee, and it may be asymptomatic. Investigations: X-ray, cartilage calcification, calcium pyrophosphate crystals in synovial fluid with elevated ESR. Treatment: NSAIDs and intra-articular cortisone. Pseudo-gout, hydroxyapatite arthropathy, females more than males, and shoulder joint is the commonest site. And then we have systemic sclerosis or scleroderma. Definition: connective tissue disorder characterized by thickening and fibrosis of the skin with involvement of blood vessels and internal organs. In fact, scleroderma means hard skin. Pathology: vasculitis with collagen deposition all over the body. Clinical picture: females to males 3:1. Skin: we have early edema, later in duration hardening of the skin with loss of its elasticity. Hyper or hypopigmentation with ulceration and calcification. Raynaud's phenomena: the initial complaint in 70% of all patients. GIT, esophagus dysphagia in 80% of the cases. Reflux, small intestine malabsorption syndrome, large intestine constipation. Renal: vasculitis of renal blood vessels, hypertension and chronic renal failure. Scleroderma: renal crisis, life-threatening condition manifested by sudden onset of malignant hypertension and acute renal failure. Cardiac: cardiomyopathy, pericarditis, pericardial effusion, ischemic heart diseases, heart block due to fibrosis of the conducting pathways. Chest: interstitial pulmonary fibrosis, pulmonary hypertension, aspiration pneumonia due to esophageal reflux. CNS: headache and stroke during hypertensive renal crisis. Musculoskeletal: myopathy, arthralgia, and rarely arthritis. Variants or types of scleroderma: diffuse, limited, localized, systemic sclerosis sign, and overlap syndrome. Overlap syndrome: association with other autoimmune diseases such as polymyositis and SLE, at least 2 other connective tissue disorders. Systemic sclerosis sign: without scleroderma, it's very rare, internal organ involvement without skin manifestations. Localized scleroderma without internal organ involvement, just morphia, I don't know the pronunciation, it's MORPHOEA, local patches of scleroderma on the skin only. Then we have diffuse and limited. Diffuse scleroderma: severe internal organ damage, generally more life-threatening. Diffuse skin hardening involving trunk, proximal, and distal limbs with the face. While limited scleroderma or crest syndrome, skin hardening is limited to fingers, face, feet. Internal organ involvement is not severe, much better prognosis. Crest: calcinosis, CREST, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and T for telangiectasia. Investigations: elevated ESR and CRP, anti-nuclear antibody positive in 90% of the cases, rheumatoid factor positive in 25% of the cases, anti-SCL, SCL 70 positive in 30% of diffuse scleroderma, anti-centromere positive in 70% of limited scleroderma or crest syndrome, and finally biopsy. Treatment: relieving symptoms and limiting damage, penicillamine, slow progression of skin diseases because it decreases collagen production. Steroids, indicated for treatment of inflammatory myositis, pericarditis, or pulmonary fibrosis, but it doesn't help skin. Symptomatic treatment: arthritis, NSAIDs, Raynaud's, calcium channel blockers, and for renal crisis we give ACE inhibitors, which are the drug of choice. They are life-saving. And then we have osteoporosis. Osteoporosis, it is the most common metabolic bone disease characterized by reduced bone density and increased risk of fracture. By the WHO, it's bone mineral density that is 2.5 standard deviations or more below the young adult mean value. If it's between 1 and 2.5, then this means osteopenia, while the normal bone is more than 1. Classification: we have primary and secondary. Primary is divided into type 1 and 2. Type 1, postmenopausal osteoporosis, most common in women, of course, because it's after menopause due to estrogen deficiency. High incidence of vertebral fracture. Type 2, senile osteoporosis, occurring in old age, seen in both females and males with ratio 2:1. High incidence of hip fracture. Secondary or type 3 osteoporosis, occurring at any age, affecting men and women equally due to many causes. Causes and risk factors: genetic factor is the single most significant factor. Endocrine: decreased hormones, estrogen deficiency in females, hypogonadism in males, or increased hormones, Cushing's syndrome, thyrotoxicosis, or hyperparathyroidism. Drugs: cortisone, heparin, anticonvulsant, chemotherapeutics. Malignancy: multiple myeloma, leukemia, inflammatory rheumatoid arthritis, ulcerative colitis, GI malabsorption, primary biliary cirrhosis. Others: prolonged immobilizations, smoking, and alcohol intake. Clinical picture: again, it is the most common metabolic bone disease without the S, asymptomatic until a fracture occurs, just radiological osteopenia. pain, particularly low back pain or neck pain, the most common site of fractures are the forearm, Achilles fracture, spine, vertebral fracture, femur, hip fracture, kyphosis, and abdominal protuberance may follow crushed vertebrae. Investigations, lab, calcium phosphate and alkaline phosphatase are usually normal in primary osteoporosis. Investigations for the cause, cortisol level, Keften, lift and Tift thyroid function test, imaging, X-ray showing fractures and osteopenia, bone mineral density BMD measured by DEXA without the EDXA scan. Treatment, prevention, diet, adequate dietary calcium and vitamin D intake, weight-bearing exercise, avoid smoking and alcohol, correct any secondary cause. Medical treatment, calcium and vitamin D supplements, bisphosphonates, alendronate, anti-resorptive, calcitonin, estrogen replacement therapy, raloxifene, but we have to give it in some tissues with the anti-agonist. In others, to avoid endometrial and breast cancers, recombinant human parathyroid hormone. It stimulates new bone formation without the S, I'm sorry. Low back pain. Low back pain is a common musculoskeletal disorder. Nearly everyone has low back pain sometimes. Etiology, mechanical, inflammatory, infection, neoplastic, metabolic osteoporosis, osteomalacia, Paget's disease, neoplastic bone tumors, whether primary or metastatic, and intradural spinal tumors, infection, osteomyelitis, Pott's disease, TB, inflammatory, rheumatoid arthritis, seronegative spondyloarthritis, such as ankylosing spondylitis, mechanical, lumbar disc prolapse, lumbar spondylosis, lumbar spinal stenosis, medical condition occurring with aging, where spinal canal narrows and compresses spinal cord and nerves at the level of the lumbar vertebrae, osteoarthritis, fractures, bad posture sitting, standing, leg length difference, and congenital such as scoliosis. And then we have referred pain to the back, such as prostate cancer, pancreatitis, pyelonephritis, and peptic ulcer. Others, we have psychogenic low back pain, not others. The intravertebral disc is formed of central gelatinous part, nucleus pulposus, surrounded by fibrous tissue ring, annulus fibrosus, and covered from above and below by cartilaginous plate. Acute disc prolapse, sudden rupture of the annulus fibrosus, followed by herniation of the nucleus pulposus. This compresses the spinal roots, and it may occur at any age due to trauma, lifting heavy objects, or jumping to the floor from a height. Spondylosis, gradual, progressive degeneration of the intervertebral disc, especially in freely mobile discs such as cervical and lumbar regions, leading to herniation of the nucleus pulposus. Diagnostic approach according to history of low back pain with morning stiffness in young patient, ankylosing spondylitis. Spinal stenosis, back or leg pain worsening with walking, pseudoclaudication, with prolonged standing and relieved by sitting inflection. Mechanical causes, pain radiating to buttocks or thighs only through sciatica from nerve root compression radiates below the knee to the foot. Examination, back signs, tenderness, deformity, signs of nerve root compression, disc herniation, lumbar disc prolapse occurs at the level of L4, L5 level or L5S1. In 95% of all disc herniation, it's from L5S1. Motor manifestations, weakness of dorsiflexion in L5 root, weakness of plantar flexion in S1 root. Sensory examination, saddle anesthesia, decreased sensation in buttocks, perineum, and posterior thighs. Bladder dysfunction and straight leg raising test is positive, indicating sciatica. Differentiating features between mechanical and inflammatory low back pain. We have mechanical, inflammatory, we're going to compare between them. Mechanical disc prolapse, inflammatory ankylosing spondylitis. Onset in mechanical is acute, occurring at any age, and exercise worsens it. While inflammatory, gradual onset, the age is young, usually younger than 35, and exercise makes it better. Morning stiffness is present in mechanical, spinal tenderness localized to L4-5-S1, motor sensory bladder manifestation positive in mechanical, scoliosis positive, while other systems and sacroiliac hip involvement are negative in the mechanical lower back pain. While in inflammatory, we have sacroiliac hip involvement, other systems involvement, but we don't have scoliosis or motor sensory bladder manifestations. Spinal tenderness is diffuse with evident morning stiffness. Investigations, X-ray, CT, MRI, myelography. in cases where red flags are present, and those red flags include, I'm not going to say narcissism, they are recent significant trauma, unexplained weight loss or fever, previous or current cancer, osteoporosis or chronic corticosteroid use, age greater than 70 years, focal neurological deficit, duration greater than 6 weeks. Treatment of mechanical lower back pain, instructions: rest position, avoid prolonged standing, sleep on medium firm mattress, avoid lifting heavy objects while unsupported back, weight reduction, medical treatment inside during acute attacks with muscle relaxants, local measures, exercise program, flexion exercise, physical agents such as heat, ice, massage, ultrasound, electrical stimulation. It decreases pain, muscle spasm, fibrosis, and adhesion, and it provides local anti-inflammatory effect. Surgical treatment: microdiscectomy, laminectomy, or spinal fusion. Indications are failure of conservative treatment in reducing pain or progressive neurological symptoms such as leg weakness or bladder disturbances. If we're going to compare between the differential diagnosis of neck pain and back pain, mechanical: in neck pain we have trauma, cervical spondylosis, disc prolapse, muscle spasm. In back pain, trauma, lumbar spondylosis, disc prolapse, muscle spasm. Inflammatory: in neck pain, seronegative arthropathy, rheumatoid arthritis. In back pain, brucellosis and seronegative arthropathy. In metabolic, for neck pain, osteoporosis, osteomalacia, which is the same for back pain. Neoplasm for neck pain, metastasis, multiple myeloma, lymphoma, and it's also the same for back pain. Referred pain: for back pain we have pancreatitis, peptic ulcer, cancer pancreas, renal colic, myocardial infarction, sometimes prostate or cervix disease. While for neck pain we have angina, pancreas tumor, and finally aortic aneurysm. And this concludes our chapter for today.